Have you ever had excruciating abdominal pain and wondered what it was? Well, let's hope it's not what this patient had. Dr. Diagnosis here, your internet radiologist. Let me take you along as we diagnose another patient emergency from the ER. This is a 64-year-old man complaining of abdominal pain, and as per usual, that's all I know. So let's save a life. Running through quickly, the astute amongst you will already see what is wrong, but however, let's go back and proceed system by system. We don't want to miss a subtle finding. The lungs, heart, stomach, and gallbladder are all unremarkable. The liver and spleen also have suspicious small fluid adjacent to them. The kidneys are unremarkable. The prostate is enlarged and the bladder shows signs of chronic outlet obstruction consistent with the patient's age. The colon has diverticulosis, but no acute diverticulitis. As we move into the distal small bowel, we see that it's decompressed. But as we move more proximal, we find multiple suspicious appearing dilated small bowel loops with air fluid levels, inflammatory changes in the mesentery, and areas of small bowel wall thickening. As we investigate these dilated small bowel loops further, we come upon a transition point, the place where a dilated bowel loop transitions from dilated to sharply decompressed, a finding diagnostic for small bowel obstruction. However, something is wrong here. Normally, the small bowel after the transition point is decompressed since it's obstructed from the bowel contents proceeding distally through it. However, here we see the bowel distal to the transition point is also dilated and fluid-filled. In fact, the loop after the transition point is even more dilated and inflamed with marked inflammation in the mesentery, the fat and blood vessels supplying the bowel. And then we come across the feared second transition point. It's a good thing we slowed down. Had we called this simply a small bowel obstruction, the patient might have died. This patient has the far more dangerous high-grade stenosis, caused by either a closed-loop obstruction or internal hernia. These far more dangerous small bowel obstructions can lead to bowel ischemia, cutting off the blood flow and oxygen to the affected bowel and eventually causing bowel infarction or bowel death. We have to look for any possible signs of early bowel ischemia, such as gas in the superior mesenteric vein or portal veins, pneumatosis in the bowel wall, or free air in the abdomen. Now that those are clear, we have to put in an emergency page to surgery because this patient might need emergent surgery to reverse this high-grade obstruction. Thanks again for joining me on another remarkable journey through the mysteries of emergency room consults to radiology. Join me again next time, or until my wife figures out what I'm doing and tells me to stop.